Hi everyone, so I am Christy DeLuca. I am a speech language pathologist and clinical voice specialist. So I also happen to have a chronic voice neurological disorder called spasmodic dysphonia. So some of you watching this may have spasmodic dysphonia, or some may be professionals treating spasmodic dysphonia, or even just other people who are looking to learn more about the disorder. So I'm going to do a brief overview about spasmodic dysphonia, so that hopefully you come away with a little bit more education and knowledge about the disorder. So spasmodic dysphonia, or SD as it's more commonly known as, is a neurological chronic voice disorder, which means that it stems from the brain. And so there's dysfunction in the way the brain is sending signals to the vocal folds and the way the vocal folds are perceiving the sensory input and sending signals back to the brain. And so in that loop, there is an impairment. And so what happens is that the vocal folds are told to move a little bit too much. So normally when we speak, vocal folds come together and they vibrate against each other to make sound. Now for SD, what's happening is the vocal folds are spasming when they either come together or when they're coming apart. And so what that does is it causes some changes in your voice, as you can imagine. So normally if we have a smooth vibration pattern, this is now being disrupted by the spasms. So there's two main types of spasmodic dysphonia, and then I'll talk about one third type. So the two main types are AD or AB. So AD is known as the adductor type, and AB is known as the abductor type. And so they're a little bit different in how they present. There's a third type called mixed spasmodic dysphonia, which I'll talk about in a second. So the adductor, the AD, basically it occurs in spasms of the vocal folds when they're coming together, or really when it's transitioning from a consonant that's voiced to a vowel. So for somebody with AD, they're going to have the most difficulty with voiced sounds. So voiced sounds are anything that has voice when you say it. So something like da, right? That has voice when I say it. Ba, z, m, ga. All of those are voiced sounds because you can hear me produce voice when I make the sound. Versus there's voiceless sounds, and those are k, t, sh, right? All of those are just modulations of my airflow, and I don't have any actual voice to them. So we can tell usually which sounds are going to be the most difficult based on what type of SD the person has, or likely vice versa. We can tell what type of SD the person has likely by the types of breaks that they're exhibiting or the sounds that they're saying are the most difficult. So if somebody is saying that H's and F's and T's are really hard and they're complaining of kind of these breathy breaks, that they're losing their breath really often when they go to say these sounds in the vowels that follow the sounds, it's likely to be AB or abductor spasmodic dysphonia rather than the other type, that's AD. So for abductor, the vocal folds are spasming when they're coming apart, again, or the transition of when they're going from a voiceless sound where they're apart to then going back into a vowel, which is voiced. And so if they're spasming in that open phase and the vocal folds are open, you're going to have a millisecond or two more of that open breathy phase, which allows that breathy break to occur. So for AD, it's the opposite. For AD, the most difficult sounds will actually be voiced sounds. So this might be, again, da, z, all of those have voiced in them. So an individual with AD is not going to have breathy breaks, but they're actually going to have strange strangled breaks. So you might hear the vowel just cut off completely in the middle of a word. So for instance, something that follows D might be really hard for me. So the word dog, I might say it dog, right? Something like that, dog. right? Because I have that break in the middle of the vowel and it just kind of cuts off on me. And I can also feel that in my throat. The reason why that is happening is because the vocal folds are spasming when they're coming together. And so I'm going from a voiced sound to a voiced vowel, and the vocal folds are together and they're spasming when they're together. So they're together for a little bit more time. So if they're sticking together for a little bit more time, they're kind of pressed. It's making a more pressed quality, and it's not allowing the voice to be smooth, and that break is occurring when the vocal folds spasm. And that's why the vowel sounds kind of just like choppy or cut off. So those are the main differences between AAB and AD. There are certain sentences that can help tease them apart. So that's why if you have ever been diagnosed with spasmodic dysphonia, or if they were trying to figure out which type of spasmodic dysphonia maybe you may have been given several sentences to help differentiate that. So something for AB might be Peter bit the tape, or the puppy bit the tape. All of those are P sounds mostly. So you're going to have a lot of, and T sounds, and you're going to have a lot of those breathier breaks. Or Harry hit the hammer, right? Harry hit the hammer. You're doing something like that, that's likely to have a component of the abductor AB type. Versus if you have a sentence like, we eat eggs every Easter, right? And you struggle through that sentence and you do something like, we eat eggs every Easter, that's likely to be ADSD, where those vowel onsets are really harsh and strange or really difficult. So those are just two examples of kind of differentiating sentences. If you count from 60 to 69, you may have had to do this in your voice evaluation at one point. If you count from 60 to 69 and you find that really difficult and you're 60, 61, right, something like that, that's likely to be AB. So abductor, which means you have the breathy type of breaks, versus something like 80 to 89. If that's really difficult for you, you likely have ADSD or adductor spasmodic dysphonia, because again, you're having those vowel onsets. 80. You're starting with a hard onset for that E sound. 80, 81, 82, right? That's kind of harsh in my voice, and that's a hard onset, and I'm having almost a break at the start of that word, which can be really difficult. So you can kind of test yourself if you're trying to feel those different symptoms and see which one's easier. If both are hard, you might have something called mixed spasmodic dysphonia, which could mean that you actually have components of both the abductor type and the adductor type. So for this type of spasmodic dysphonia, it's rarer, but you might have some breaks that are after the voiced sounds that are the strained, strangled breaks that I was talking about. But then you might also have some breaks that are more breathy, so after the voiceless sounds. So you might have a mix of both, and that's why it's called mixed spasmodic dysphonia. The AD, the adductor type, is much more common than the AB, and adductor is also easier to treat in some senses. So it's more responsive to Botox than is the abductor type. Abductor is a different muscle that's Botox than the adductor Botox injection. So there's several adductor muscles for the vocal folds. So basically, that means the muscles that bring the vocal folds together. There's several pairs of muscles that do that. And then there's a different muscle that is responsible for opening the vocal folds, which is the problem muscle in the abductor type. So it's the actual muscle that controls the either opening or the closing of the vocal folds that is Botox. It's not the actual vocal folds themselves, not the surface tissue of them, but it's actually the muscle that is controlling the movement of the vocal folds that's Botoxed. So obviously this is not a cure because it is treating the symptoms. It's lessening the spasms of the muscle. But again, we talked about how the origin is actually in the brain, and the origin is actually neurological. So it's not a long-term treatment, but rather a symptomatic treatment. So with Botox, you do have to get re-injected. Depending on your dose and depending on the severity, it could be anywhere from 3 to 6 months for people on average. So there's a lot of considerations with Botox. It can be really, really helpful for some, and for some, depending on what type, severity, the location of the injections, the strength of the injections, it might not be as effective. I will talk about treatment options in a following little video here, but I just wanted to get on here and really just kind of describe the physiology, the neurology, very on a very basic level. And then really the differences between the main types of spasmodic dysphonia. And then we can, again, go into more treatment, but I think it's really important and empowering to have this education when getting a diagnosis of spasmodic dysphonia and really understanding what is happening, what's causing the changes in the voice, because it can be really frustrating and can be really disabling, and to at least have an understanding of why it's happening, what's going on when you're feeling it, why it's named, what it is named, and the rationale behind the primary form of treatment right now, that is often really helpful. So I'm going to do, again, some videos on Botox injections, which is the gold standard of treatment still. I'm going to do some videos on voice therapy techniques, and also upload some of my prior webinars that I did with the National Spasmodic Dysphonia Association, because I find that voice therapy can also be helpful depending on situation and circumstance for several people. So I will go ahead and make some more videos as we go along here. Please feel free to comment if you have any questions or reach out to me. I will put my email here. You can find me at speakingboldly.com. Again, my name is Christy DeLuca, speech language pathologist. Feel free to look at my blog at speakingboldly.com, or you can browse the channel for upcoming videos that might be helpful to you and your condition. All right, stay well, everyone.